Okay, so I think we just, my name is Yoshi Onuma. I'm working in Galway in Ireland. We have a colleague research center for advanced imaging and Corab. I hope that you can see my slide.
Yes, we can see your slide.
Very good. Yeah, so in Ireland, we have some research center where we have international fellows, such as the Tsunin Tsai here, and he was really helping also for this presentation. But not only that, he's very much involved in the new studies performed in this core lab and research center. And so I think he's from originally from Taipei Veterinarian Hospital, veteran hospital, and he's doing a great job here. So I just want to introduce, my colleague John here, and nice to meet you. I think it's nice to connect with our colleague in Taiwan, and today my topic is the CT-guided left main stenting with the supraflex screws. So before going to the topic, I think you are all interventional cardiologists, so maybe interested in the technical detail of the case. But before going to that, I want to talk about a role of the CT in complex coronary artery disease, because of the change in the guideline, nowadays the CT is used as the first line of the tool for the diagnosis of the chest pain. In European practice, we have seen the increase of the CT as a test performed before going to the cath lab. So approximately 30%, 40% of the cases in Europe, we have a coronary CTA before going to the PCI. And if you look at the imaging modalities, of course, OCT IVAS has a very high resolution of the 15 micron or the 100 micron for OCT and IVAS respectively. But with the new generation, the CT, the spatial resolution really get improved. So that with the newer generation, it's almost 200 micron, which is equivalent of the invasive coronary angiography or even for the IVAS. And there was, of course, some sort of additional cost, but if already the CT was done before the PCI as a part of the routine diagnostic pathway, of course, I think it's good to use the CT images to plan the complex PCI. So this table is from the consensus of the EAPCI about calcium. So it's more focusing on the calcium, but even with the calcified lesions, you can use a CT to plan the complex PCI, such as left main, etc. So these are the kind of the pyramid of the coronary artery disease. You have a population without any coronary artery disease. Of course, those are the most healthy patient, and we used to use the CT to rule out those patients without CAD. But I think we can also use a CT for the non-obstructive coronary artery disease, which is NOCA, if the FFR is CT is greater than 0.8 for those patients in yellow. We don't do the PCI. However, we can use a CT for the monitoring of plaque regression, progression, also detection of the vulnerable plaque or the high-risk plaque on this population, which might be treated with the medication or medical therapy. And then we have one vessel disease, two vessel disease for the population for the target of the PCI. Of course, you can use that for the diagnosis, but we can look into the functional severity of the lesion stenosis. We can use CT for the planning for the PCI. And on top of the pyramid, there is the population left main three vessel disease. Typically, those patient is treated either by CABG or PCI. And for the clinical decision, it is important to do the syntax score. And the syntax score was developed for the angiography, but we have shown that the CT can also do the syntax score. So the CT syntax score was initially validated against angiography, but now we have updated version of the CT syntax score, which was published this March in one of the journal. We introduced a different definition of the chronic total occlusion. In CT, if the occlusion is equal to greater than 6 millimeter, then most likely it's a chronic total occlusion, because sometimes in CT the subtotal and total occlusion was a little bit difficult to judge. But now we have a data that we can use these lengths of the occlusion to predict that it is totally occluded or not. We also can see the heavy calcification of in the CT, which is very important for the PCI, because treatment of the PCI is basically bringing the device from proximal to distal. So if you have a calcification, even without a stenosis, sometimes it predicts the difficulty during the procedure to bring the stent or the devices. So those are the to evaluate the distribution of calcium is important for the PCI planning. And we have for the good inter-observer reproducibility of this syntax score based on CT, and that was just published. So you can use the CT for the syntax score assessment and make a treatment decision on the patient with the complex artery disease. So this is just an example of very heavily calcified CT. You can see that almost no lumen because of the blooming artifact created by the CT. You don't see the lumen, but in the MIP, the maximum intensity projection, you can see the distribution of calcium very well. And of course, sometimes we are misled by the calcification, because sometimes we really see that it's occluded or very stenosed. And sometimes it's not the case on angiography, but in this case, you can really see that the heavy calcification. Lumen is also compromised in right coronary artery, and LAD was not really stenosed in this case, despite this a lot of calcification in the proximal to the mid part. Yeah, so this is an example of the CT with the calcification. You see this left main disease. If you look at the cross section, a majority of the lumen were occupied by the calcification. If you look at the FFRCT has a unique algorithm to reduce the artifact of the calcium on CT, and you can really see that already in the left main there was a significant drop of the pressure, which is 0.69 in the distal part of the left main. Yeah, and this is the actual angiography, and you can really see the tight stenosis in the distal left main, and it's a 101 lesion. In general, CT can predict very well the plaque volume. This is the publication from the group of Daniele Andreini. They used the 256 rise CT, which is a new generation. And you can really see that in general, the plaque volume analysis by IVAS and CT correlate very, very well. You can see that the almost superimposed cumulative curve of a plaque volume between the CT and IVAS. And of course, for the calcified plaque, there was a slight overestimation of the plaque volume using the CT, and there was a comparison between the calcium and the OCT in the same patient in the same lesions. You can really see that the calcium area was slightly or sometimes more overestimated by the CT, but in general there was some correlation. And if the degree of the calcium is very high, then there was a little bit more difference by CT. But I will show you the some tricks that you can modify the window width and also the window level. It's a little bit technical, but you can. This is the same images, but you just adjust the window width. Then you can really minimize the effect of the calcification on the interpretation of the CT. So, and also that to rotate the image is also helpful to not to be too much biased by the presence of the calcium, for example, in this case. And recently, last year, that in the European Heart Journal, the consensus for the CT management was published, and there was one figure in supplement about the CT guidance. So for the CT guidance, for the diagnostic evaluation, you have a CT syntax score, you have a functional region severity. When you see a lot of calcification, you can look into the calcium load mapping, because like here, there's too much calcium. Maybe you might go for the cabbage, but if you have to do the PCI, you will see that how much calcium you have in the proximal part of the coronary artery disease. And if the cross section of the calcium is the greater than 273, or the Prague region calcium score is greater than 453 or equal to 453, then you should better to prepare the cath lab by using the additional adjunctive therapy such as lithotripsy or the rotablator, or in some case laser. And for the CT, you can use the CT for the stent site selection. You can select the landing zone, and also you could look into the plaque composition for the non-target vessel, because sometimes the other vessel has a non-calcified plaque, and if those plaque has a high-risk plaque, you will think about the additional therapy. You could remember there was publication of Prevent last year, showing some benefit of preemptive stenting on the very high risk region. Of course, CT doesn't have such capability to detect the very high risk plaque. Still, I think positive predictive value of that kind of analysis is still a little bit questionable. But in the future, if you have a little bit more specific criteria of vulnerable plaque or the high risk plaque, we might also think of doing something on such a coexisting plaque. So the CT guided PCI is the first. You can look at the 3D coronary tree overview. You can see functional significance, also per lesion. You can also do the virtual PCI plan using the heart flow, for example. You can have online procedure guidance. You can synchronize the image of the CT in front of you and also the projection of the angiography, so you can facilitate the co-registration of the CT and angiography in front of you in the cath lab. We can also calculate myocardial mass at risk, and plaque composition is sometimes important, especially for the calcification. It's important for the interventionist to consider the additional adjunctive therapy. And then we can also, before going to the cath lab, we can see the ostium position, catheter selection. So those are the, in principle, how we can use the CT. And then now we are going to the case. So I think that this case was prepared with John. We presented that from the Toulouse in France in one of the sessions in the EuroPCR. So patient was 81-year-old male. Presentation was de novo crescendo effort angina, CCS class 3. The patient didn't have cardiovascular risk factors. He has some moderate aortic stenosis, mid-grade and 23, but there was no urgent indication of the surgery or any other therapies. So, and the symptom is very strong, and it's not explained by the moderate aortic stenosis. So the patient has a pretest probability high 52% because of the age and the gender. You could see that some diagnostic test was warranted according to the ESC guidelines. And now we have this CCS guidelines, which was published in 2019. We have in the upcoming ESC, the next week, probably we will have an update of the guidelines for the chronic coronary syndrome. So maybe we should soon update this slide. But for the moment, the coronary CT is the class 1B as the initial test to diagnose coronary artery disease with a patient with a symptom. So in this case, CT was chosen to look into the anatomy of a coronary artery. So this is the VR image, volume ring rendering image. You can see the anatomy. It is right dominant anatomy. You can see the lumen using the MPR, multiplanar reconstruction, PD and the right corner artery, some plaque, and there was some significant calcium in the distal left main. And there was another calcified plaque in the mid LAD. So if you look at the right corner artery, there was, I think, 4, 5 spots of the calcium in along the right corner artery, but none of them are significantly stenosed. You can see the lumen very clearly up to the end of the PLB branch. And on the heart flow analysis, the distal FFR was negative 0.86 in PD and 0.85 in 16. So the right corner artery, no indication. For the left main to the LAD, you can see that there was significant calcification and pressure already dropped in the distal left main. And there was a significant drop, so it's less than 0.5. So there is a significant ischemia or the physiological significant lesion in the distal left main. If you look at the cross sections, proximally the diameter was 4.3 millimeter. Distal left main, it's calcified plaque more than 270 degree in the distribution in cross sections. There is also the LAD lesion continuous from the left main, somewhat calcified. Area was 6.7, so maybe not too significant, but there was a continuation of plaque. LAD middle in this after the left main disease, reference vessel diameter 3 millimeter. And for the circumflex, there was some plaque with calcification, but diameter stenosis was 39%, so maybe not too significant in terms of stenosis. So before going to the cath lab, John measured all the components of left main. So it's a calcified lesion, MLD 1.2 millimeter, reference proximal is 4.3. Reference distal is 3.0 millimeter. So if you try to fix this lesion, we need to have a stent which can accommodate the diameter difference of 3 millimeter to 4.3, 4.5 millimeter. That was the reading of the CT. And of course, in Europe, the indication of PCR and cabbage is somewhat strict. So we have to discuss in the heart team with the surgeon if the patient is amenable for the PCI or the patient should have undergo the cabbage. So we did the syntax score based on CT without angiography. There was 24 point in the LAD and left main. The right corner artery, there was no significant stenosis, so there's no point. Circumflex is only together with the left main. There was a proximal stenosis just after the left main, but there's no point. So after looking at the LAD and left main, we score the two lesions, so which is the 24. So in the iPhone, together with SMT, we had software and application for the iPhone and Android, which enable us to calculate the syntax score online, but also the calculation of the 10 years mortality based on some of the baseline characteristics demographic of the patient. So in this case, we have anatomical syntax score of 24. Functionally, it's also significant. So the functional syntax score remained to be the same, 24. The patient is 81 years old, creatinine clearance 64 milliliter per minute, and the ejection fraction 69%. There was a left main disease, gender is male, COPD no, etc. So if you put this component clinical parameters together with the CT-based syntax score, you could calculate the 10 years mortality and 5 years event rate based on the PCI and cabbage. So these data was initially acquired from the Syntax 1 trial, but this score was well validated using the recent registry such as Credo Kyoto. So it's multiple time validated. So we could calculate if the we operate the patient or if treat the patient with the PCI, the mortality at 10 years is 45.5%. And for the 5 years MACE, it is 30.58% for the PCI and 30.6% in the CABG. So it's kind of the equivalent risk for the CABG and PCI. And after looking at the anatomy, the heart team decided to refer the patient to PCI because it's somewhat calcified, but it's well enough simple for the treatment of the PCI. And for the 81 years old patient with the aortic stenosis, not yet the indication of the valve, they tried to deserve the option of the surgical revascularization and the valve intervention. So we discussed also maybe after the PCI 5 years later, probably the patient needs some TAVI procedure. So that's also taken into account for the treatment decision of this patient. So before going to cath lab, John also looked into the viewing angle to look at the ostium perpendicularly, like in a TAVI procedure. We need a viewing angle of LAO20 cranial 30. LAO cranial is the best angle in the cath lab to look at the ostium. If you want to see depict the bifurcation left main, then the best viewing angle was LAO or caudal spiral view, LAO 50 and caudal 35 degree. So we have those information before going to the live cases because the patient was treated during the live cases. And the planning was the following. So for the selection of the catheter, we can use a 7 French 3.0 EBU or the XB guide as your preference. We need an adjunctive therapy device because in the cross section, the extension of the calcium is greater than 270 degree. We also have osteal disease of the circumflex, but it's not really significant. So we decided to go to use some adjunctive therapy, either rotablator or lithotripsy, but we think that there was some space lumen kept in the distal left main. So our first choice was a lithotripsy with the 4 millimeter balloon. Working angle it's already described. So if you want to for the ostium, it's a areocranial. If you want to depict the left main bifurcation perfectly, it's a spiral view, but the LAO 50 and caudal 35. Stent selection, we decided to use the supraflex, and probably we need a 30 millimeter to cover the region of 25, so maybe 28 millimeter, and proximally we need to make a pot of 4.5 millimeter, and that was planning. There was another region in the mid LAD, so we used the PCI planner from the heart flow to look into the FFR. If you fix the left main, then the FFR will be 0.94 in the proximal LAD, and there are no significant pressure drop anymore in the distal part of LAD. So you don't need to treat 2 regions. Probably we can just fix the left main region, and that will normalize the pressure drop in the entire LAD. So we decided to treat only the left main first. So so this is just the same scheme. So in this case, we have all the information, and this cross-sectional calcium information request us to be prepared for the adjunctive device preparation. And in this case, we decided to use the lithotripsy as a first primary mode of the device choice for the adjunctive therapy for the calcium modification. So that was the actual angiography during the live case demonstration in the EuroPCR. So we went for the 7 French XB 3.0 catheter, and you can see that there's a significant stenosis, and you can really see that some calcification also on angiography. So we directly went for the 4012 millimeter shockwave balloon. You can really see that's effectively expand this severely calcified lesion. We did 12 cycles of lithotripsy, so all the pulse was used for this lithotripsy balloon. There was a good predilatation, but there was some dissection after this predilatation, so we decided to go straightforwardly for the Superflex cruise. Initially, we thought 3.0, but for the LED, the vessel looks a little bit larger than 3.0, so operator decided to go for the 4020 millimeter Superflex cruise. It's inserted from to the LED. After the deployment of the first stent, we see that there was some sort of a plug shift and also potential dissection of the ostium of the circumflex. So it was a provisional one stent technique, but because we see that it's compromising the ostium of the circumflex, we converted to the two stent. So what we have done is we did port and then we rewire, and then we inserted another supraflex screws into the circumflex to seal this potential dissection to 512. And then it's kind of the T-stent technique. It was a provisional one stent converted to this tap or minimum T. And then after putting the stent, we also did the kissing balloon to be sure that the opening of the circumflex is maintained properly. And in the end of the procedure, we also did the report with the 5.0 millimeter non-compliant balloon. And we also did the OCT just to check if there's any more optimizations needed or not. So this is the final angiography, and we perform the OCT after that. So you can really see the pullback of the OCT here. You see the wide opening of circumflex in the 3D. But also you can see the very good expansion of LED and also the proximal left main. And you can really see that there's no dissection or no malposition apparent ones. And you can also appreciate that there's a really chunk of the calcium which is recognizable on OCT, and plaque modification. The lithotripsy works very well to expand this supraflex in very calcified region. So that was final OCT and 3D reconstruction. So of course we need OCT or IVAS to detect something happening during the procedure. So the load of the imaging is intravascular imaging is stayed there. But potentially we can use more information from the CCTA. We can do the hard time discussion, also do the planning of the PCI. And maybe we can skip one OCT or IVAS pullback because we know that enough from the CT. But and if you need optimization of stent, of course, you need intravascular imaging during the procedure. But I think it's very good to use the information of the CT because it's already existing, and we see that the gradual increase of the usage of CT before the catheterization. So initially 2 years ago, it was in our all-comer trial, 20% of patients had a CT before the PCI, but now it's increasing from 20 to 30% and increasing more. So it will be the kind of, at least in Europe, the trend that you have a CT before doing any catheterization. So probably that's the kind of the future workflow. And of course, if you need a CABG, you can also refer the patient to the CABG without doing the invasive angiography. The last part is just try to oversee the data of the cruise. Of course, dedicated study for the left main is not yet available. This is one of the network meta-analysis comparing a different type of the stent, including the Supraflex and the other ultra-thin strut stent, Orsiro, and also the My stent. So if you look at the one of the graph, sucra plot of this network meta-analysis, you can see that the supraflex is one of the best, even compared with Orsio as a reference. You can see it's not significant, but the point estimate is lower than the risk of reference, which is Orsio in this case. So you can see that supraflex has a very good efficacy in terms of the preventing the TLR. However, I must say that the study included in the meta-analysis was the Talent, which was all-comer trials performed in Europe. Left main was only the 1.5%. So we don't have a specific data on the left main. And as you could already know, that the supraflex screws has a very unique design in terms of the stent. There is an alternate Z-link in between this valley to valley of the crowns, and that can be in-phase design to provide agility, and it has a quite good mechanical properties, the foreshortening, optimal crossing profile, radial stiffness, deliverability, which is very good, and that was also confirmed by the feedback of multi-vessel talent trial, which we are conducting now, not for the left main, but specifically for the multi-vessel disease, three-vessel disease. So there was also one publication in the European Journal of Medical Research showing that the cell diameter after the bifurcation is very high with the supraflex screw. So there's no concern to do the left main stenting crossover, and you can open the cells very widely. So this could be considered as one of the stent for the left main disease. This is a slide from Krishna that there is the maintenance of radial strength of the supraflex. So sometimes we are afraid that it is ultra thin and maybe doesn't have enough radial strength when it's overexpanded, etc. But apparently there is some increase of radial strength if you overexpand these supraflex screws, because the crown is usually kind of the W shape, and it can be a little bit recoil, but if you overexpand, this zigzag part will be completely a circle, and that probably provides more support in the overexpanded part of the stent, which we also observed in other devices. So just to end up with that, this is a trial we are doing in Galway and in Europe, which is called the multi-vessel talent trial, enrolling 1,550 patients. And enrollment is almost finishing this month. So we randomized de novo three-vessel disease patient either to the supraflex or the synergy. We use the QFR to guide the procedure. So we send the clinical site sent to the core of the angiography. We analyze the QFR and get back to the site and indicate that which region to be treated according to QFR. We did the syntax 2 trial before the multi-vessel talent. At that time, we used the IFR to guide the procedure and planning of the procedure. But in this trial, we use now QFR, the angio-based FFR simulation. Intravascular imaging post-procedure is mandatory, and then we use the contemporary CTO technique to treat the total occlusion. And we have a very cutting-edge optimal medical therapy, including the short DAPT, aspirin prasugrel 1 month, and after that prasugrel monotherapy for 11 months. We are left main is actually exclusion criteria, but in some cases, if the stenosis in the just proximal LAD, the stent is ending up in the left main, which is allowed in the protocol. So we have 103 patients who received the stent in the left main. LAD extent to the left main is 85 stent. The circumflex to the left main was 26 patients, and there was some sort of deviation from protocol, left main bifurcation to stenting patient, but it was probably just one case. We have seen that the some technique used in the left main, contemporary left main treatment. So you can see that the pot kissing report is the kind of the most commonly used strategy. So it's most likely the one stent strategy, and you use the pot and you open the strut towards the circumflex of the LAD and kissing, and then you do the report just to reshape the proximal part of the stent. And followed the other most common approach is pot plus kissing without report in the end. But those two are the most common strategy for the stenting and ballooning after stenting. So we are almost the end of the recruitment. We need 1,550 patients. Today we have a 1,500 patient randomized, so we need to have a 50 patient more to go, and we expect that this month and next month we can achieve this goal. So soon after we finish the enrollment and follow-up, we can provide you the more data on the three vessel disease, but some of them are also treating left main. So we will have soon the more data on the supraflex in the left main. So thank you for attention.
Thank you for
lecture. And before starting the question, may I introduce Professor Onuma? Yes, Professor Onuma was graduated from Tohoku University in Sentai, and he completed his PhD program in Netherlands, and he also editors of textbook including OCT and bioresorption. He is the expert in atherosclerosis research and image. Now, and also we know that he has many published, and he peer review many journals, more than 700 papers. Now, he is the professor of interventional cardiology in National University of Ireland, Galway, and the medical director of Core Research Centre and Core Lab for Coronary Image and Atherosclerosis. And thanks, Professor
Onuma's excellent talk. And now I have a question that we know that after the CT guide, the PCI, then for the layman intervention, image is crucial for further confirm the result, and we can use the OCT or IVUS. After the CT guide, which strategy and the image study you will use first? I mean that which kind of case you will use OCT and which kind of case you will use IVUS to confirm the result?
Yeah, thank you for your question. I think it's an important question, and yeah, so there was maybe I can show one or two slides, but my personal choice usually is OCT if it's not ostial lesion. The reason is that after stenting, it's easy to interpret the image by OCT. And you could see that in October trial, for example, published last year, then there was a benefit of the OCT guidance in October trial, which clearly showed that the benefit, especially in the beginning. And the angio guide arm also containing some of the IVUS guided in left main. So I think the OCT could be used in the left main. That's really clearly shown by Lemon and also the October trial. So I think, of course, sometimes we worrying about left main is too large or that there is not enough flash, but recent trial clearly show that OCT could be used in the bifurcation stenting, including the left main. So that's the one thing. And then for the IVAS, of course, if you look at the meta-analysis of the intravascular imaging, especially in left main, there was also survival benefit already in the IVAS from some time ago. So I think you can use either IVAS or OCT, but I think what is important is you get accustomed to any one of the intravascular image. And for personal preference is OCT, but I think also the IVAS is good. And whenever you doubt about the complication, like in the case I have just shown, there was doubt about the protruding strut into the left main, etc. Then I think you need to look into the IVAS and OCT. And I think if you look at the protocol of October, there was multiple phase you can use intravascular imaging. In my talk, I just suggest that maybe we can skip the pre-procedural intravascular imaging by replaced by the CT. But if you use the intravascular imaging for the guidance, I think it's important to go through all the step. Like before procedure, you do the intravascular imaging. If you don't have the CT, after stenting and after recrossing to the wire, I think it's important to be sure that you don't create any problem by the external wiring. Sometimes the recrossing wire is outside of the stent, so you can imagine if you do the kissing balloon after such configuration, you will put the metal into the main vessel. And so I think this year also there was one publication from a group of the October that the if you have a kind of an unintended stent deformation, those patients has a very high event rate, almost 27%, versus if there's no such findings, those patients doesn't have an event. So it's important during the OCT or during the procedure, you look at the intravascular imaging and to make it sure that the wire is not taking the wrong place. And of course, in the end of the procedure, you have to check this expansion of the stent using the expansion index, etc. So I think intravascular imaging, I think the choice of the IVAS OCT is probably there's a preference, but if you use it, I think we should use it systematically, and for each step, it's good to be sure that you are on the right track.
Thank you. And beside me, there are also co-chair with Dr. Liu and Dr. Wei from Market Memory Hospital and Minsheng Hospital. And also for the audience, do you have any question for Professor Osuma?
Hi, Dr. Onuma, and this is Dr. Liu from Hsinchu Mackay Memorial Hospital. It's wonderful. Thank you for your talk, and we learned a lot. And I believe that CT angiography is very beneficial, and it helps interventional cardiologists in terms of PCI. And this is also true in Taiwan. And from your talk, I'm just wondering, like at the hospital that you are based or the regions that you are based, is it a routine practice to perform CT angiography before, like for patient with angina? And the second question is that from your experience and from your talk, we saw that you had the heart team approach, heart team discussion without diagnostic angiography, without the catheterization. And I'm just wondering, like, what percentage of these patients, or what percentage of the patients change their treatment strategy after, like if you decide that you're gonna have PCI, but after the diagnostic angiography, and then you change strategy and change it to CABG, or the other way around. I'm just wondering what percentage of the patients are there. Yeah, thank you.
Yeah, thank you for the very excellent comment and question. So the first of all, talking about our center, so we just introduced the CT dedicated for the cardiology. And we are still, it's the first year or second year, so we don't have too many cases, but we have a very dedicated CT for the cardiology. So the number of the patients who had CT before PCI is also rapidly increasing. And sometimes, for example, in a CTO, because sometimes the the angiography is also not so clear on the the CTO, so we do the kind of additional CT if the patient agree to undergo the CT, and that is sometimes helpful to plan the PCI for the total occlusion, because you can see the more the collateral from the same side or the contralateral side, because CT is the contrast is coming from the both side of the right and the left. So that's the one thing. And in general, in Europe, as I mentioned, that the frequency of the availability of the CT before the cath lab is increasing. And probably we think that there is a decrease of the at least the diagnostic angiography, because if you have a good CT, you have also the functional significance. And you could remember that in UK, for example, the NICE, which is the national recommendation for UK, is endorsed CT coronary angiography together with the FFR CT some time ago, 7 years ago. And last year, they have shown that in the fish and chip study, there was a survival benefit of using this CT-based diagnosis together with the FFR CT over the conventional angio-based strategy. So there was some kind of a basis that we go for the CT-based diagnostic and also potentially planning of the coronary artery disease procedure. Then your next question is about heart team. So for the heart team, in this case, we did the heart team by CT. So in the syntax-free study, which we performed, I think 5-6 years ago, we randomized the two heart team. The one heart team look at the angiography and made a decision of the CABG or PCI, and the other heart team only look at the CT without angiography and made a decision of revascularization, more CABG or PCI. So the agreement was very significant. I think 85% of the cases, there was a complete agreement with the choice of the PCI and CABG, and the kappa was very high. So we believe that from that study, we know that you can make a decision of the PCR CABG based on the CT. And how many times it will change the decision on the CT, etc. I think we have to still do it, that kind of study. But what I can tell you is that if the patient is going to the PCI anyway, those patients will undergo the angiography at the time of procedure. So if the CT was somewhat wrong, you can correct the strategy immediately when you are in the cath lab. So for the CABG, it is for the surgeon. So you might think that it might be more tricky because you have a CT, but you don't see that invasive angiography. So recently we did the fast track CABG trial where we asked the surgeon to operate just looking at the CT, without looking at the invasive coronary angiography. And the feasibility of the surgery in that population was 99%. We enrolled 200 patients, but only one case you could not operate with the CT only based on the CT. So the feasibility is high, and we look into also the 30 days graft occlusion by repeating the CT 30 days after the surgery, and it has a 90% of the patency rate of the graft, and which is in the literature, if you do that also on the angiography, it's almost 90%. So the occlusion rate was similar. So there was evidence that you can also operate the CABG solely based on the CT images. So I think the world will change. Of course, we need more data, but early study really shows that the feasibility of the CT-based complete CAD patient management So I think I expect that more and more heart team will endorse this concept, making the clinical decision based on CT. You can also plan and execute a procedure solely based on the CT. But I agree that we need a little bit more data. So. It's on mute, so maybe can you unmute? I cannot hear you because I think in team it's mute. I don't know, somebody technical team, can you unmute the computer? Because I cannot hear the voice.
Okay.
Yeah, now I can. Yes, yeah, thank you.
Can you hear
yes.
me now?
Yes, yeah.
Okay. Yeah, so thank you. Yeah, this is great. And so with the advances of cardiac CT and the improving accuracy, do you predict that CT-FFR or FFR-CT can replace the FFR in the future? Like, so in the future, we don't need to do FF during the PCI. What do you think?
Yeah, I think that's also the great question. And I think if you look at if you think about function of the FFR, you can use it for the indication of PCI, of course. So if it is the primary purpose of the FFR, probably if you have a FFR CT, you don't need to do that in the beginning of procedure. If you want to use it for example, post-procedural guidance, and some data shows that if you can achieve the high FFR value after the procedure, you have a better outcome. Then if you want to use that kind of purpose, maybe still you have to do this invasive measurement. And I think that basically what I expect. And there is also the angio-based FFR, like QFR, like in multivessel challenge, we use this QFR technology to guide the procedure for the complex PCI, and that might be also another way to kind of substitute the invasive FFR. Of course, for the angiography-based FFR, there was some cases inaccuracy. I think the AUC curve in our publication was around 0.72, 0.76. So in some cases, like if the complex anatomies are there, you might still need to the invasive pressure measurement. But I think in general, if you have a good FFR CT, good quality of the CT, that can potentially replace the pre-procedure wire measurement.
Thank you. And any audience have questions to Dr. Professor Onuma?
Professor Onuma, thanks for your excellent lecture. I'm another Dr. Liu. I'm from China Medical University Hospital. I have a few questions regarding the current CTA. As we know, the image-guided or functional study-guided PCI will improve patients' outcome. We hope that CT-guided PCI will also improve patients' outcome. In the daily practice, are there limitations in your hospital? Are there limitations for using coronary CTA in daily practice, such as renal function or arrhythmia, etc.?
Yes, yeah. Thank you, Dr. Lee, for this a good question. So, yeah, of course, the contrast and the linear function is always a problem. Also, the arrhythmia, like atrial fibrillation, sometimes influence the efficacy and accuracy of the CT analysis. But with the new generation of the CT, even with the presence of the atrial fibrillation, with some rate control, we could have reasonable images. So it's also really depends on the generation of machine, and the machine is really improving almost day by day. And we have now the photon counting CT from the Siemens, which has also very high resolution of images. So you could probably see that in a couple of years from now, there is a more prevalence of the photon counting CT. And it's not only the Siemens, but the other companies are probably going to catch up. So I think the CT image will really improve very quickly. That's our prediction. So.
Thank you. We know that coronary CT is very sensitive for the interpretation of coronary calcification. However, will severe coronary calcification limit the interpretation of coronary CTA or coronary CT-FFR in your daily practice?
Yes, yeah. So as I have shown that in the beginning of the slide, there was a way to little bit modify the impact of the calcification. So it's technical, but if you go into the CT lab and little bit adjust the window width and window level, then you might minimize the effect of the calcification. And also there was a dedicated kernel for the reconstruction of the CT. So if you have a good communication with the technician, etc., you might have improved the image by utilizing the dedicated kernel and reconstruction method. Maybe you can use it for the CT. Previously, we have also checked the in the Syntax 3 trial, the calcified plaque influenced the diagnostic accuracy in comparison with angiography. But if you use the FFRCT, there was not so much influence of the detection of significant stenosis. So we are somewhat confident that we can use this technology in the calcified region.
And the interpretation of coronary CTA is experience demanding. Do you discuss all the image with your radiologist, or you can do all the things?
Yeah, that's also an excellent question. As to most of the time, the cardiologist or the radiologist who is looking at the image is sort of an issue, because sometimes competition between the two department is existing. So, but in our case, whenever we have a positive or the patient who is undergoing the PCI, we look at the image by ourselves. I think the key is that you have to see the image by yourself. And as an interventional cardiologist, I think probably you know a little bit more than the radiologist about you are going to face in a cath lab, because the radiologist is more for the diagnostic. But if you look at the image, you will think about the procedure. So for the procedure planning, I think it's very important to look into the image by yourself. So.
Okay. And as we know, the AI is a hot topic on the future medicine. Do you have the plan to integrate AI in the coronary CTA, such as automatic coronary syntax score or PCI planning?
Again, excellent question. So we have been working for the automatic CT syntax score. We used to collaborate with the HeartFlow, but also the other companies. So it's a little bit ongoing project, and certainly I think it's the one of the target we want to achieve, because I think for the interpretation of syntax score, you need expertise. But if it is automatic by AI, that is be more easy and more reproducible. So there's no doubt that we need such kind of development. And you can really see that in the United States, there was 4 or 5 companies already utilizing the AI for their software, like heart flow use AI, and also for the plaque analysis, Clearly and Elucid and AutoPlaque. Those are the software companies already using the machine learning to develop and train their algorithms. So I think AI will be certainly the important role in interpretation of CT, and we will work hard on the automated CT syntax score. So
it's a business secret.
yeah, it's not
Okay.
secret, but I cannot provide any timelines yet. But believe us, we are working on that development.
Okay. My last question is that back to the sponsor of this great meeting, SMT. Does supraflex stent has unique property in left main stenting and in your study?
Yes, so I think we heard sometimes some concern that it is ultra thin, and there's some sort of the doubt amongst the interventional cardiologists. Ultra thin is not good enough for the big vessel, the left main. But as I have shown that in the slide, we have 100 patients in the multi-vessel talent trial. We don't know the result yet, but we haven't had any catastrophic episode or whatever. So I think also looking at these radial strengths in a big vessel, it's very reassuring that if you overexpand that, the radial strength a little bit goes up. So there was no issue or the concern about radial strengths in overexpanded stent. So I think, of course, we need a little bit more data, and multi-vessel can provide some data if the follow-up is available. But for the moment, we don't have the concern about using this supraflex cruise stent in the left main. And as I have shown that the live case in the EuroPCR went very well. So I think at least we have some data to show the feasibility. But I agree that we need to collect more data specifically for this left main for the supraflex cruise.
Thank you. Thank you for your excellent answer. Thank you.
So anyone here have any questions to Dr. Professor Onuma? Thank you, Professor Onuma. And because time is limiting, and do you have a question? Okay, because time is limited, and I will close this section. And as we know, image-guided layman intervention is very crucial, and no matter OCT or IVUS. And Dr. Antonio Colombo said that IVUS is mandatory to layman intervention, and many papers point out that OCT has better outcome compared to angiographic guide. So I think that image guide is very important to layman intervention. Now we have the CT guide to layman intervention, and we can see the angulation of the bifurcation, to see the case status of calcification, and to know the lesion length. So I think that with these tools, we can complete our procedure and better strategy for and better outcome for PCI intervention. And we hope that we can see Professor Onuma in Taiwan soon. Will you come here in the future?
Yes, yeah. I'm willing to see you face to face. I think last time my visit was 8 years ago in Taiwan, but we have always a good experience with a colleague in Taiwan, and we also have, as I have shown, that one colleague from Taiwan, and he's excellent. So I really want to pursue the collaboration with interventionists in Taiwan. And thank you for having me in this meeting. Thank you.
Thank you. Thank you, Professor Onuma, again, and hope you have a nice day. Thank you.
Yeah, thank you. Thank you. Bye-bye.
Bye-bye.